Hello everyone. In this section we look at peri-anesthesia complications as an overview, and we identify the common complications that may occur during general anesthesia. Before we do that, we categorize the complications into avoidable or preventable group and the unavoidable and unpreventable events. Complications are usually unexpected and unwanted events, and they may affect up to 10% of anesthetics overall. Some of these complications could be quite frequent, such as arrhythmias or hypotensive episodes and adverse drug reactions or episodes of inadequate ventilation. And they could be quite reversible and they could be preventable. However, if these complications are not addressed in a timely manner, then they may lead to quite severe complications and have very severe outcomes for the patients. So the underlying causes for these complications could be patient-related due to their pre-existing comorbidities, or they may happen during the system failures or equipment malfunction or communication breakdowns, or it could be due to clinicians' errors in judgment during the care delivery. Overall, once these complications are identified, the aims are to eliminate them or minimize them, or throughout the process of patient selection with appropriate assessment, we try to identify these complications or the potential of occurring and then prevent them in a timely manner. In particular, the GA complications, the reported events are events such as anaphylaxis, aspiration pneumonitis, peripheral nerve damage, damage to teeth, and embolism. Although the occurrence might be infrequent and rare, however, these are the most common reported events that we can attribute to the delivery of GAs. When we attempt to specify an overview of complications from general anesthesia, we need to take into account that multiple factors may have a role in terms of amplifying or magnifying the impact or the magnitude of these risks. Things such as pain, for example, could be very multifactorial as a complication. It could relate to the type of surgery, patient's characteristics, and even clinicians' decision making. For example, choosing a specific type of medication for acute pain management, that could result into the type of complication or its magnitude. Nausea and vomiting, similar to pain, in overall estimates it may impact up to 30% of the population. However, in higher risk groups, that may be represented as high as 70%. Damage to teeth, for example, it may impact 1 in 4,500 cases. Having a sore throat and laryngeal trauma could be a common and a transient complication that we could see the patients presenting with. Anaphylaxis being a small risk, however, it could have potentially severe and very significant outcomes for patients and staff. Overall, the majority of patients may present with some extent of respiratory and cardiovascular compromise due to the technique of general anesthesia or positioning, the volume status, and so forth. Aspiration pneumonitis, it may impact up to 5.5% in adults, however, a great variability in pediatric patients. Hypothermia due to exposure, time of surgery, level of interventions, type of medications, that could manifest at a variable degree in patients as a risk for GA. Hypoxic brain damage, hypoxia in itself being a significant complication. However, if it's left unaddressed, that could also deprive the brain tissue, and the brain damage could prove irreversible and quite significant as an outcome. Other risks of GA: nerve injury, particularly nerve injury to the limbs. This again relates to the type of patient, type of surgery, and type of positioning. For example, an elderly person versus a younger person in prone position, and the type of nerves that could be impacted. Awareness during anesthesia could be quite traumatic if it affects the patients, and although the occurrence is quite low, however, it is a potential risk. This might be higher in certain cases, such as obstetrics and cardiac cases. Having the venous or arterial embolism by air or thrombus, that could pose a potential risk that would complicate the cardiovascular system even further. Another common complication with GA is complaints of headache and backache. That could be due to a magnitude of reasons, medications, or volume deficiencies. Then we look at the range of severe complications that could be very idiosyncratic. That refers to the reaction of an individual, particularly due to their genetic makeup, things like malignant hyperthermia, saximethonium apnea, and reaction to inhalationals. And that could be sometimes quite hard to detect because they may not be present. This might be the first time they are having surgery, and then they have never been exposed to that agent prior to that episode of care. Iatrogenic, and these are the ones that could be caused by the clinicians due to a magnitude of reasons, deficiency in training, lack of access to the timely equipment, or inappropriate handovers and communication failures, and that could result to compromise in patient care. An example could be an attempt to insert an CVC line, and as a result the guide wire puncturing the anatomy where pneumothorax could result. Cognitive decline, this is another emerging area of anesthetic risks, the two extremes of patient age groups, more so in the elderly cohort due to the pharmacological agents that we use in anesthetic with GA delivery, that could also manifest in neurotoxicity and eventually cognitive decline, and it's a variable amount of deficiencies in cognitive performance over the course of time after a GA. And of course, due to a combination of other causes, there could be death as an event due to receiving general anesthetics. Anaphylaxis, although the risk is quite small, however, it may manifest from some of the most common signs as redness, itchiness, difficulty breathing, lower blood pressure, edema, and nausea and vomiting. That requires appropriate patient assessment prior to procedure in order to identify any causative agents before they could do the risk or the damage to the person. Prompt recognition and control and management of the condition is quite essential. If we can identify the cause, we need to remove it and eliminate it, and the rest would be priorities in terms of ABC of airway, breathing, and circulation management, and follow up on the resuscitation protocols as per case required. Decline in the level of consciousness and losing the reflexes, protective reflexes during GA would put the patient at the risk of aspiration pneumonitis. That is when the stomach contents could travel from the stomach to the lungs or through the airway tree, and this process could cause damage to the lung tissue or the alveoli, and that inflammation may eventually lead to infection, but could prove fatal in certain cases. So to minimize this risk, adherence and assessment of patients to the fasting protocols are quite essential. Application of cricoid cartilage to the high-risk groups such as pregnant women, unfasted emergency cases, people with gastric reflux, they are the good candidates for cricoid cartilage pressure or cricoid pressure. At the same time, pharmacologically, if we try to increase the gastric emptying or motility and neutralize the contents of the stomach, decreasing the pH or the acidity of the stomach contents would also help to minimize the risk in case the contents does find its way to the lungs, and that way the amount of risk with damage will be minimized. Peripheral nerve damage. This is a risk for all types of anesthetic techniques, and this is when nerves are compressed for longer periods of time due to bad positioning or exaggerated positionings beyond the range of movement for a joint, for example. And when we think about the common nerves that can get affected, it would be the limb nerves, lower and upper limb nerves such as ulnar nerve, peroneal nerve, and brachial plexus, which is communicating with the upper limbs or through the upper limbs. The responsibility of prevention lie upon every team member intraoperatively or during the perioperative journey of the patient, and that includes anesthetists, surgeons, technicians, and nurses. And when we think about prevention, we need to think about the means and mechanisms for patient safety's sake, the utilization of pressure area care devices, gel mats, and also avoiding the extreme postures, trying to extend the limbs beyond their normal range of movement. So we need to communicate, we need to be vigilant in transfers, we need to use appropriate padding in order to prevent this. At the end of their procedure, also the documentation and assessment of unexplained nerve pains of other than the site of surgery, we need to investigate and undertake the appropriate assessments. If we look at thromboembolic events, they could pose a major or significant risk as well, that in some cases that might prove fatal, and that could put the respiratory or the circulatory system into severe compromise. In order to prevent that, prophylaxis need to be in place either by medication of blood thinning agents such as heparin or compression devices and stockings, and this needs to be acted on and planned prior to procedure, and we need to adhere to the guidelines in order to prevent thromboembolic events. And proper assessment and recovery also would prevent major complications before the severity is proven to put patients' life in danger. The risk of damage to teeth is quite significant through airway management processes like rigid laryngoscopies, and this constitutes the need for appropriate documentation and assessment prior to the procedure. Damage to teeth may require greater accountability from the anesthetist's liability of claims point of view, and the most common affected teeth would be the upper left incisors, and that's where there is a potential risk of damage during laryngoscopies, where the blade may come into contact by exerting the extra pressure with the wrong direction towards the teeth. The teeth could be damaged, broken, or chipped. Hence, preoperatively, we need to make sure that we have done a thorough assessment from a nursing or medical point of view or combined, and any variation needs to be documented prior to ensure that quality of care is not compromised.